Chapter 15, Pain Management During Childbirth. So in the following slides, we're going to talk about pain management options and the nurse's role with pain management during childbirth. Childbirth is quite unique in terms of pain itself. There are several different components of the pain process. It's a very unique type of pain, unlike other pain patients might have experienced in the past, such as a bone breaking or an infection site that might be painful to touch. So it's very, very unique. It's always important to remember that pain is incredibly subjective and personal, and what other influences might be contributed to a patient's labor pain could also be cultural considerations. So just really important to remember that pain is subjective, it is personal, and that there are also other influences in a patient's pain perception during labor. Differs from other types of pain, that labor pain that we had talked about previously. It's part of a normal process, and that is something we cannot stress enough to our patients, that there is nothing abnormal that's going on at the time. Labor pain is a normal process. Preparation time exists. It is not like pain is started from the first positive pregnancy test. These patients have typically, ample enough time to kind of prepare for that labor process and have those expectations for labor pain. It is self-limiting. Labor pain is not constant but intermittent, kind of like those waves in the ocean. They come forward and then they relax, and they come forward and then they relax. Very regular type of pain there once active labor is established. And that the most important part is that labor pain ends with the birth of a baby. Adverse effects of excessive pain include physiological effects, such as fear and anxiety, that fear, tension, pain cycle patients can exhibit. It increases maternal, metabolic, and respiratory rates. So patients have an increased heart rate, they can have increased respiratory effort, maybe engaging their accessory respiratory muscles, and they could have psychologic effects as well as having kind of a traumatic event associated with labor and birth pain, or are feeling very negatively about their labor and birth, so much so that they might feel impacted by that later in the future as well. Fear and anxiety stimulates that fear, tension, pain cycle of the sympathetic nervous system, releasing that epinephrine and norepinephrine. The epinephrine releases the beta receptors that relaxes uterine muscles and improves vasodilation, pooling of blood in other maternal vessels, and decreases blood perfusion of the placenta. So that's what occurs with those beta receptors. When norepinephrine is stimulated, those alpha receptors are stimulated as well, uterine and generalized vasoconstriction occurs, increased uterine muscle tone, and reduced uterine blood flow. So we really want to be considerate of that for a patient's labor and delivery, because we want increased blood perfusion to the placenta, and we want to increase uterine blood flow, decrease those catecholamines from being released, which are the stress hormones as well. We want to reduce that fear, tension, pain cycle by finding ways to kind of break through that. We reduce blood flow to and from the placenta when we stimulate that sympathetic nervous system and have the release of epinephrine and norepinephrine. It reduces effective uterine contractions. So that fear, tension, pain cycle could actually impact a patient's ability to continue on with the labor process and kind of create a more irregular labor pattern, one where perhaps that patient is not quite getting into that active labor phase because they're just fighting against each contraction. Variables in childbirth pain. Physical factors. Some sources include that tissue ischemia, cervical dilation, pain from that thinning out and opening of the cervix itself, pressure and pulling on pelvic structures, as well as distension of the vagina and the perineum during the birth of the baby. In slide 7 of 31, we can kind of see a little visualization there of those nerves that are stimulated during labor and delivery, during the contractions, during the physical dilation and opening of the cervix. We could see pain stimulation from cervical dilation enter the spinal cord at these segments. So that's L1 to T10 there. And pain stimuli from vaginal and perineal distension travel through the pudendal nerve and enter the spinal cord in these segments. So that's S2 to S4. And we can see that there in that nice visual there. Other physical factors include tolerance or perception of pain, labor intensity. So some patients will perceive pain differently. You might have a patient who is 4 centimeters who is having a respiratory rate of 35 and a heart rate of 140 and is just not coping well with her labor, while another patient can be deep breathing, very relaxed, perhaps just kind of using those relaxation techniques to get her through each contraction. So it's, again, very, very subjective. Cervical readiness, how is that cervix in terms of its receptiveness to labor? Is it thinning out? Is it opening up? Is it moving forward in the labor process? How is that fetal position contributing to that? Some fetal positions can cause greater discomfort for patients, such as a baby looking towards that ceiling in the occipital posterior position, or OP position. We call these babies stargazers as well, where the large part of the fetus, the fetal back, and the large part of the bones, that occipital bone there, press directly against mom's pelvis and mom's back. This is what's called back labor. This is a very uncomfortable fetal position for moms to labor in. So that can cause increased pain as well. So we'd encourage our moms to reposition to see if that helps that baby kind of rotate and come out of that position. Fatigue and hunger play a big role in it. On average, labor, once active labor is established, can last anywhere from 12 to 18 hours. So these patients are exhausted. They've been working for many hours, especially in first-time labors, and that really might contribute to their physical factors as well. As well as caregiver support. If a patient doesn't have the greatest support, they might feel greater fatigue there, less kind of willingness to kind of move forward in their labor. Variables in childbirth pain, psychological factors. Those include culture, like I had said in that first slide. Culture plays a big role in labor and delivery, and for some cultures, it might be the expectations for moms to be very quiet and reserved throughout their labor pain, while other cultures, it might be the expectations for them to be very vocal throughout their pain. Anxiety and fear, again, playing that big role, especially in that fear, tension, pain cycle. Previous experiences can impact this as well. If a patient has a history of sexual assault and during their labor they're having cervical exams and it's very intimate type of care, that could really influence the way they perceive their labor, as well as preparation. Patients oftentimes who have done prenatal education are more prepared and have that anticipatory guidance as to what the next steps of labor might feel like or look like for them, versus somebody who has done a minimal amount of preparation. They might be kind of more anxious as to what the next steps are, not knowing any information from the baseline, as well as the influence of support systems really can play a big role, especially if you have very engaged support people that are helping that mom kind of move through and cope with each contraction. That could really influence a patient's perception of pain as well. Non-pharmacological pain management advantages include that it does not slow labor down. There are no side effects or risk of allergy from repositioning a patient. Some pharmacological methods may not eliminate labor pain. They might not be appropriate for our laboring patients. And it may be the only realistic option in an advanced rapid labor. So if there is no time to administer an epidural or administer any IV analgesia or anything like that, it might be the only option to help our patients cope throughout labor. Other non-pharmacologic pain management limitations include desired level of pain control is not always achieved. I had mentioned it in the previous presentation, but there is no painless birth quite yet. We haven't mastered that quite yet. So understanding that a patient's desired level of pain control might not actually be the end goal to achieve during labor and birth. Even a well-prepared and highly motivated woman may have a difficult labor and need analgesia or anesthesia itself. So it's always important to have that kind of open mindset and that open communication with your patient, knowing that if we cannot kind of keep with the plan of a natural birth, that we do have other options. Non-pharmacologic pain management, the gate control theory of pain, transmission of nerve impulses controlled by neural mechanisms in the dorsal horn of the spinal cord act like a gate to control impulses transmitted into that brain, kind of allowing that transmission into the brain. Pain is transmitted through small diameter sensory nerve fibers. So that, again, that gate control theory of pain, that gate is open, pain is being transmitted into the brain. Stimulation of large diameter fibers in the skin block conduction of pain through small diameter fibers, thereby closing the gate and decreasing the amount of pain relief. And we have a nice little visualization of that in slide 13 of 31. We could see that external stimuli, emotions, expectations, memories, culture, personal patient experiences kind of coming through. We see the sensory nerve fibers, and we can see that kind of entrance and exit of pain through those gates there. Non-pharmacologic pain management, preparation of pain management. So ways that we can have our patients more prepared for the labor and birth and the pain associated with it. Childbirth education classes are a great way to prepare our patients prenatally. Talking about the ideal time to prepare is before birth. Perhaps while they're in active labor is not the most appropriate time to talk about expectations of pain and discuss at length other options. A support person learns specific methods to encourage and support parents throughout labor. So that's a great tool support people can pick up during a childbirth education class. The nurse then has the opportunity to teach and reinforce the normalcy of birth, patterns, what is the expectations in early labor, active labor, transition, and second stage labor. Talking about the latent phase of labor is the best time for intrapartum teaching. And that latent phase would be that kind of earlier part of labor, having that irregular contractions, probably be a better opportunity versus a more regular, faster paced labor. Non-pharmacologic pain management application techniques include relaxation techniques, encouraging, different types of breathing techniques, paced breathing, patterned breathing, teaching our patients that. Could be hydrotherapy, encouraging our patients to get into a warm bath or take a nice shower. That mental stimulation, a lot of patients like to use some visualization or some guided imagery as well, and that could help them kind of be used as like a focal point for non-pharmacological pain management techniques. Let's move forward to pharmacological pain management in labor. We want to talk about how some pharmacological pain management does affect the fetus, how it affects maternal physiological alterations, effects on the course of labor, effects on complications with labor, as well as interactions with other substances. So, for example, a new type of pain management that's being used in the United States in the last couple of years is nitrous oxide. Nitrous oxide is also that laughing gas that is typically used in the dentist office. That is something that is fast acting, is self-administered by patients in labor, and has minimal to no side effects on the fetus. So that could be something that is integrated into a patient's pain management if the institution in which they're delivering has that type of therapy. Another example would be regional pain management, an epidural block. Epidural blocks are administered by anesthesiologists, and it is the injection of a local anesthetic agent combined with an opioid into the epidural space, or the space outside of the dura and the spinal cord. It provides substantial pain relief from contractions and does anesthetize the area of the birth canal, but does not provide 100% coverage. It does a great job of really helping to numb those sensations, but it's not going to give us 100% coverage. It can be extended upward, meaning it can affect a patient's kind of respiratory effort if they have what's called a high epidural, an epidural that travels upward. It is localized. So typically, this medication is the best therapeutic effects are going to be felt from the site of placement and below. So while extensions can happen upward in terms of medication, they are more rare. It is more adequate pain relief without complete motor block. So these patients have what I like to call as kind of a muted sensation. They might feel pressure from their contractions. They might feel kind of their legs and their lower extremities like warm and tingly. They're still going to be able to move them slightly. It's just definitely going to be a muted sensation. So these patients would not be candidates that would be up and walking around and moving out of the bed. These would be patients that would be in the bed. That's the safest environment for them since they won't have that full strength in their legs there. In slide 18 and slide 19, we can see great visualizations of the spinal cord and the spinal structures there where that epidural block would be placed, again, outside of the dura there. On slide 19, we can see the epidural space is entered with the needle below where the spinal cord ends. A fine catheter is threaded through the needle. After the catheter is threaded into the epidural space, the needle is removed. Medication can then be injected into the epidural space intermittently or by continuous infusion, depending on the institution there, for pain relief during labor and birth. Regional pain management, intrathecal opioid analgesics. So this is medication that's injected into the subarachnoid space. This is a spinal. This is typically used for patients who are going to have a C-section. But other indications could be used for other indications that could be used as well. It is a much smaller dose than if given systemically when it is administered locally there. Women can feel their contractions, rapid onset of pain relief without sedation, so it doesn't affect the neurological aspects there. And these patients typically can ambulate during labor if they are given what is called a walking spinal block. No sympathetic block there, limited duration of action. So these spinal blocks typically last for a few hours, and then after that they kind of start to lose their effectiveness. There is no indwelling catheter in place for these patients, so they cannot be on a continuous infusion. Patients who receive these spinal blocks for a C-section are not getting up to ambulate because of the type of anesthetic used. For these spinal blocks, these would be surgical level, so they would not have any feeling or sensation in their legs. Inadequate pain relief for late labor and birth. These are medications that when administered in that second stage of labor, when a patient is fully in pushing, are not going to be as effective because of the timing of the medication. Doesn't have an adequate enough time to kind of catch up where a patient is in labor in terms of their pain management. Regional pain management, subarachnoid block, simpler procedure than an epidural block, and that has to do with the threading of the catheter. Catheter placement is seen in an epidural block, not seen in a subarachnoid block. May be performed when a quick cesarean birth is necessary. So again, another indication for this type of medication would be a cesarean section. And we can see a little bit of the differences there in the visualization in slide 22 of 31. A 25 to 27 gauge spinal needle with a stylet, occluding its luminous, pass through the subarachnoid space where the spinal cord ends. That's where the medication would be administered. The stylet is removed and one or more drops of clear cerebral spinal fluid needle hub confirm the correct needle placement. So that's how the anesthesiologist is assured that they are in the correct location by the presence of spinal fluid. Medication is then injected and the needle is then removed. So that one and done type of medication administration. In slide 23, we can see the differences between the level of anesthesia for a cesarean birth, how it does extend a little higher, versus the level of anesthesia indicated for a vaginal birth with these types of blocks. A blood patch is a procedure that is used for patients who are experiencing what's called a spinal headache. A spinal headache is a risk of having a subarachnoid block or an epidural block placed, and that is where the needle has punctured through the dura into the spinal space itself and caused a little bit of a loss of fluid. This is a very specific type of headache that patients can experience, a type of headache that is almost essentially relieved when the patient is placed in a supine position and then greatly worsening when the patient is in an upright position. So that's when they have the most loss of spinal fluid there. A blood patch procedure, during a blood patch procedure, a anesthesiologist or a nurse would remove probably 1 vial of blood from the patient in a just typical extremity blood draw, and they would use that blood and push it forward into the patient's epidural space, that space kind of adjacent to the dura there that we can see visualized over here. By placing kind of a small outpouching or small volume of that patient's blood, the epidural space and the dura are able to reabsorb that volume and have a decrease in a loss of volume, so that patient will be experiencing less symptoms of a spinal headache. And it's typically the kind of gold standard treatment for those spinal headaches. And this is typically an outpatient procedure, but it can be performed in the inpatient if the patient is still in the hospital during labor and delivery. Regional pain management, systemic drugs. These are opioid analgesics. And again, institutionally, it just kind of depends where you're practicing and what type of opioid analgesics you'll be able to see. Some include Demerol, Stadol, as well as Nubain. These are medications that can be administered through an IV push as well as an IM application, intramuscular injection application. These are medications that do have some restrictions to them. Most of these medications, if not all, cross that blood placental barrier. So there are some side effects to the baby that can be exhibited. There are some time restraints that can be exhibited. For example, Nubain does cross that blood placental barrier and cannot be administered 2 hours prior to birth. We know that labor and delivery can be a little unexpected, so that part could be challenging. And a reverse medication or an opioid antagonist that we could administer if a patient receives these medications too late in their labor include the administration of Narcan. Adjunctive medications administered with these opioids are typically antiemetics or medications to help relax mom, like Vistaril. Phenergan is an antiemetic, also known as promethazine, to help with nausea that can be associated both with labor as well as with the administration of opioid analgesics. Vistaril is a sedative and hypnotic, similar to a kind of very, very strong Benadryl, if you will, and it's to help kind of relax mom and get her kind of like type of sleepy so that she can enjoy the benefits, if you will, of the analgesia administered. Regional pain management includes local infiltration anesthesia, local anesthetic. Just prior to an episiotomy or a suture of a laceration, patients can receive local anesthetics such as lidocaine, similar to what a dentist would administer during a cavity fill. They typically administer local anesthetic to the site where it's indicated, such as a suture repair area. It does not alter pain from uterine contractions. It's highly localized to where it is administered. And rarely has adverse effects on both mother and baby. In slide 27 of 31, we can see an example of a local anesthetic being administered there. Anesthetizing medications such as Novocaine or lidocaine are injected into the skin, muscle, or cervix for fast temporary relief of pain in the perineal area. Other regional blocks include a pudendal block, which anesthetizes the lower vagina and part of the perineum, typically administered prior to a birth, but an imminent birth. Provides anesthesia for an episiotomy and a vaginal birth. Does not block pain from uterine contractions. So we expect our patients to still be experiencing pain from their uterine contractions, but have, again, more of a numb or muted sensation in the vaginal area after this administration. Moms will feel pressure, which is absolutely normal. In slide 29, we can see a great visualization of a pudendal block being administered. We can see that needle guide and where that healthcare provider is palpating for that pudendal nerve there where that medication will be directly administered, right through the sacrospinous ligament and near that ischial spine itself. So those are landmarks that the provider would use to administer this medication. A backup type of anesthetic in any obstetrical case, because we never know what cases will require true OB emergencies, would be general anesthesia. Again, why it's important to have our patients assessed by the anesthesiologist upon their admission. General anesthesia is systemic pain control. These patients have a loss of consciousness and will require an ET tube or an intubation tube, a breathing tube, after general anesthesia is administered. It is rarely used for vaginal births and still has a place in cesarean births. About less than 5% of birth in the United States is through general anesthesia. May be used unexpectedly and quickly for emergency procedures and at any stage of pregnancy. And then our last slide, we have a quick question. What type of nursing intervention is most important after the injection of epidural anesthesia?